You're listening to Who Said, a Cardiology Board Review series. No fluff, just facts.
This episode is about pre-heart transplant. We will cover definitions of advanced heart failure, indications for heart transplant, exclusion criteria for heart transplant, levels of listing for heart transplant, and serial testing while on the waitlist, all in the context of knowledge for the cardiovascular board examination and general cardiology practice. What exactly is advanced heart failure? According to the 2022 AHA-ACC-HFSA heart failure guidelines, advanced heart failure refers to heart failure in a patient who has any of the following: repeated hospitalizations or emergency department visits for heart failure in the past 12 months, need for intravenous inotropic therapy, persistent New York Heart Association or NYHA functional class 3 or 4 symptoms despite therapy, severely reduced exercise capacity, peak VO2 less than 14 mL per kg per min or less than 50% predicted, 6-minute walk test distance less than 300 meters, or inability to walk 1 block on level ground because of dyspnea or fatigue. Intolerance to RAS inhibition because of hypotension or worsening renal function, intolerance to beta blockers as a result of worsening heart failure or hypotension, recent need to escalate diuretics to maintain volume status, often reaching daily furosemide equivalent dose of more than 160 milligrams per day, or use of supplemental metolazone therapy, refractory clinical congestion, progressive deterioration in renal or hepatic function, worsening right heart failure or secondary pulmonary hypertension, frequent systolic blood pressure dipping below 90, cardiac cachexia, persistent hyponatremia with serum sodium less than 134, refractory or recurrent ventricular arrhythmias or frequent ICD shocks, or increased predicted 1-year mortality above 20% according to heart failure survival models. These are any of the things that can suggest that a patient is in a state of advanced heart failure according to the 2022 AHA-ACC-HFSA heart failure guidelines. The definition of advanced heart failure in the ESC heart failure guidelines is organized into 4 categories and is endorsed also by the AHA-ACC heart failure guidelines. It requires satisfaction of all 4 categories. 1 is having severe and persistent symptoms of heart failure, New York Heart Association class 3 or 4. 2 is having severe cardiac dysfunction defined by at least having one of these: LVEF of 30% or lower, isolated right ventricular failure, non-operable severe valve abnormalities, non-operable severe congenital heart disease, and if the ejection fraction is 40% or higher, having elevated natriuretic levels or evidence of significant diastolic dysfunction is needed. 3 is hospitalizations or unplanned visits in the past 12 months for episodes of congestion requiring high-dose intravenous diuretics or diuretic combinations, low output requiring inotropes or vasoactive medications, or malignant arrhythmias. And 4 is severe impairment of exercise capacity with inability to exercise or low 6-minute walk test distance less than 300 meters or peak VO2 less than 12 to 14 mL per kg per min estimated to be of cardiac origin. These are the 4 categories for the definition of advanced heart failure according to the ESC, and it requires satisfaction of all 4 categories. Now, meeting these criteria just means that the patient is in advanced heart failure, but that's not the same as meaning that the patient needs a heart transplant. And when the patient is in advanced heart failure, that just means that you need to start thinking about different kinds of advanced heart failure therapies. This could be mechanical circulatory support, such as LVAD or BiVAD or RVAD, ventricular assist devices, which are covered in the last episode. Or it could be balloon pumps or Impellas or tandem hearts, which are, can be used for temporary support as well. And a subset of these patients will be patients who need a heart transplant. So what are the indications for evaluation of a heart transplant? There's 6 general categories. 1 is progressively worsening or refractory CHF symptoms, New York Heart Association class 3B or 4. 2 is cardiogenic shock requiring continuous IV inotropic therapy for hemodynamic stabilization. 3 is cardiogenic shock requiring mechanical circulatory support such as an LVAD or balloon pump. 4 is recurrent life-threatening ventricular arrhythmias despite an implantable defibrillator, antiarrhythmics, and/or attempted catheter-based ablation. 5 is refractory angina without therapeutic options for revascularization. 6 is end-stage complex congenital heart disease without pulmonary hypertension. Those are the indications for evaluation for heart transplant. What about the exclusion criteria for heart transplant? This is much more detailed than the indications. According to the 2024 International Society for Heart and Lung Transplantation Guidelines for Evaluation and Care of Cardiac Transplant Candidates, which I will hereby refer to as the 2024 Heart Transplant Candidate Guidelines, exclusion criteria for transplant include the following: history of malignancy or recent with probability of recurrence, severe cerebrovascular disease, irreversible pulmonary parenchymal disease, irreversible pulmonary hypertension, acute PE, irreversible hepatic dysfunction, renal dysfunction, severe peripheral artery disease, insulin-dependent diabetes with end organ damage, severe connective tissue or disease or sarcoidosis, psychosocial instability or substance abuse, active infection, severe osteoporosis, frailty, high surgical risk, obesity, and high age. None of these are absolute contraindications, and they vary based on different variables as well as center-by-center practice. But let's go over the specific wording in the guidelines for the definitions of these categories, starting with history of malignancy or recent probability of recurrence. The ISHLT 2024 Cardiac Transplant Candidate Guidelines say that all heart transplant candidates should be screened for solid organ tumors as recommended for the general population. It's a Class 2A recommendation for colorectal cancer screening, Class 1 recommendation for prostate, breast, cervical, and lung cancer screening. Skin cancer screening by a full body examination completed by a dermatologist for all heart transplant candidates can be useful to reduce skin cancer morbidity and mortality, Class 2A. In heart transplant candidates with a history of malignancy, collaboration with oncology specialists is recommended for individualized risk stratification to assess malignancy-related survival and risk of recurrence in the context of immunosuppression, Class 1. In heart transplant candidates with a history of malignancy, heart transplant is recommended when malignancy-related survival will not impact post-transplant survival and the risk of recurrence is low based on tumor type, response to therapy, and negative metastatic evaluation, Class 1, which makes sense. They allow for low-grade cancers, such as prostate cancer or skin cancer, and also cancers that are remission for at least 5 years or more. Now moving on to severe cerebrovascular disease. They say that in heart transplant candidates with a history of stroke or neurologic signs or symptoms suggestive of cerebrovascular disease, screening for cerebrovascular disease with carotid ultrasonography is recommended. That's a Class 1 recommendation. In heart transplant candidates with clinically severe symptomatic cerebrovascular disease not amenable to revascularization as determined by a neurologist, the benefit of heart transplant is uncertain due to the risk of perioperative stroke and impact on post-transplant rehabilitation efforts and quality of life, Class 2B. How about irreversible pulmonary parenchymal disease? In heart transplant candidates, pulmonary evaluation with pulmonary function testing, i.e. spirometry, lung volume assessment, and diffusion capacity, and chest CT is recommended, ideally once optimized from a volume perspective, Class 1. In heart transplant candidates with severe parenchymal lung disease, as evidenced by chronic hypoxia from a pulmonary source or significant abnormalities in pulmonary function tests, as determined by a pulmonologist, the benefit of heart transplant is uncertain due to the increased risk of post-transplant mortality, Class 2B. In heart transplant candidates deemed ineligible for transplantation due to severe irreversible end-stage parenchymal lung disease, evaluation for combined heart and lung transplantation may be considered, Class 2B. So this concept of dual transplant evaluation is something that they mention for both kidney and for lung. Now moving on to the next one, irreversible pulmonary hypertension, which is generally a pulmonary vascular resistance of more than 3 or 4 Wood units after vasodilators. Before we can talk about what the guidelines say for pulmonary hypertension, we first need to understand the calculation of this. The transpulmonary gradient is the MPAP minus the PCWP. So transpulmonary gradient is the mean pulmonary artery pressure minus the pulmonary capillary wedge pressure. Both of these you can obtain on right heart catheterization. Transpulmonary gradient should be less than 7. More than 12 is abnormal. Now, if you divide the transpulmonary gradient by the cardiac output, that gives you pulmonary vascular resistance in Wood units. Pulmonary vascular resistance is just the mean PA pressure minus the mean wedge pressure all over cardiac output. If the pulmonary vascular resistance is more than 5, that is a contraindication to transplant because of the risk of right ventricular failure post-transplant resulting for the unresolved pulmonary hypertension. If the pulmonary vascular resistance is more than 3 Wood units, then what you can do is a vasodilator challenge to see if the high pulmonary pressures are reversible with treatment. Normal pulmonary vascular resistance supposed to be 1 to 2 Wood units. So, now that we understand transpulmonary gradient and pulmonary vascular resistance, what do the 2024 ISHLT cardiac transplant candidate guidelines say? Adult heart transplant candidates with pulmonary artery systolic pressure of 50 millimeters of mercury or more, and either a transpulmonary gradient of 15 millimeters of mercury or more, or pulmonary vascular resistance of 3 Wood units or more, while maintaining a systolic arterial blood pressure of more than 85 millimeters of mercury, the following stepwise evaluation is recommended to assess transplant candidacy. First, an acute vasodilator challenge to assess for reversibility of pulmonary hypertension. That's a class 1 recommendation. That is using nitric oxide. 2 is hospitalization with continuous hemodynamic monitoring, as often the PVR will decline after 24 to 48 hours of treatment consisting of diuretics, inotropic support, and vasodilators. That's class 1. And 3, temporary or durable MCS for unloading of the left ventricle. That's class 2A. In heart transplant candidates with severe PH that is not reversible, with measures including diuretic therapy, inotropic support, vasodilators, and temporary or durable MCS as indicated, heart transplant alone is not recommended. That's a class 3. In heart transplant candidates deemed ineligible for transplantation due to severe irreversible pulmonary hypertension, evaluation for combined heart and lung transplantation may be considered in carefully selected patients. That is class 2B. Now, how about irreversible hepatic dysfunction? In heart transplant candidates, a comprehensive assessment of liver function is recommended, including liver function tests, albumin, bilirubin, INR, biochemical assays, AST, ALT, GGT, MELD, XI score, and abdominal imaging with ultrasound or CT and or MRI. If there is abnormal initial liver evaluation, further investigations are recommended, including hepatology consultation and liver biopsy. That's a class 1 recommendation. Next, renal dysfunction. In heart transplant candidates, a comprehensive assessment of kidney function is recommended, including 1. Historical trends in kidney function, 2. Kidney function as measured by estimated glomerular filtration rate GFR and 24-hour creatinine clearance when hemodynamically optimized, and 3. Comorbidities known to impact kidney function. If there's abnormal kidney function, further investigation is recommended, including nephrology consultation, renal ultrasonography, and estimation of proteinuria for assessment of intrinsic renal disease. That's a class 1 recommendation. In heart transplant candidates with established GFR of less than 30, evaluation for simultaneous heart-kidney transplantation is recommended, class 1. In heart transplant candidates with established GFR of 30 to 44 and evidence of chronic kidney disease, such as small kidney size or persistent proteinuria more than 0.5 grams per day in the presence of stable hemodynamics, evaluation for simultaneous heart-kidney transplantation is reasonable, class 2A. Next is severe peripheral artery disease. In heart transplant candidates with symptoms of peripheral arterial disease, diminished peripheral pulses, atherosclerotic disease, or the presence of risk factors, screening for peripheral vascular disease with ankle-brachial indices is recommended. That's class 1. In heart transplant candidates with clinically severe symptomatic peripheral vascular disease, especially associated with non-healing ulcers, as determined by a vascular specialist, the benefit of heart transplant is uncertain due to the risk of perioperative limb ischemia and impact on post-transplant rehabilitation efforts and quality of life, class 2B. Next, insulin-dependent diabetes with end organ damage. The guidelines say, in heart transplant candidates, ophthalmologic consultation to determine the presence of retinopathy can be beneficial as a surrogate for duration of diabetes and degree of diabetic control and vascular or kidney involvement, class 2A. In heart transplant candidates with diabetes and end organ damage with poor glycemic control, A1C more than 7.5%, delay in heart transplant evaluation and listing is reasonable until diabetic control is improved, class 2A. Then we have severe connective tissue disease or sarcoidosis. In heart transplant candidates with connective tissue disease or sarcoidosis, focused multidisciplinary collaboration is recommended to determine the impact of the connective tissue disease on post-transplant survival rehabilitation efforts and quality of life. 2. The impact of immunosuppression on the progression of the connective tissue disease. 3. The risk of cardiac recurrence. And 4. Connective tissue disease-specific extracardiac manifestations such as pulmonary hypertension, pulmonary parenchymal disease, aspiration risk, and or arthritis. That's a class 1 recommendation. In heart transplant candidates with connective tissue disease that is expected to shorten post-transplant survival, that is associated with severe non-cardiac disease, or that is not controlled with pre-transplant immunosuppression, heart transplant is not recommended. Class 3, no benefit. Next, we have psychosocial instability or substance abuse. The guidelines say that in heart transplant candidates with a history of illicit drug use, at least 6 months of abstinence is recommended prior to transplant listing. It lists identical statements for alcohol use disorder and tobacco smoking. For all of them, you need to be 6 months abstinent before they recommend transplant listing. They also say, in heart transplant candidates with a history of active cannabis use, a recommendation for abstinence prior to evaluation and listing is reasonable due to reported infectious risk and potential drug-drug interaction post-transplant, class 2A. Now, how about active infection? In heart transplant candidates, screening for chronic or latent diseases that have a risk of post-transplant reactivation and may warrant pre-transplant treatment or post-transplant surveillance is recommended, including but not limited to human immunodeficiency viral infection, HIV, Chagas disease, tuberculosis, HBV and HCV infections, and surveillance for geographically restricted specific pathogens may be warranted. That's a class 1 recommendation. In heart transplant candidates with certain infections, heart transplant is not recommended. These include active infections requiring ongoing antibiotic treatment, except those infected durable LVADs, and HIV with opportunistic infections or related malignancy, lack of stable antiretroviral regimen, detectable viral load, and or low CD4 count. Class 3, no benefit. They also need you to get up to date on vaccinations. In heart transplant candidates, vaccine history and assessment of seroprotection as appropriate should be reviewed, and age-appropriate vaccinations administered ideally at least 2 weeks prior to the transplantation are recommended. Live attenuated vaccines should be avoided unless transplant can be deferred to 4 weeks after receipt of the live attenuated vaccine due to concern for ongoing viral replication, class 1. Severe osteoporosis is another one. Heart transplant candidates should be assessed for osteoporosis and fracture risk, class 1, but they do not make any explicit recommendation about what to exclude. Then you have frailty. In heart transplant candidates, assessment of frailty can be beneficial to identify actionable targets for improvement in conditioning and perform risk assessment of transplant candidacy, class 2A. In heart transplant candidates, regular exercise is tolerated as recommended, ideally in a structural program as if available to prevent or improve frailty, class 1. In heart transplant candidates with severe frailty that will preclude adequate post-transplant rehabilitation efforts and is not expected to improve with restoration of cardiac function, heart transplant is not recommended, Class 3, no benefit. Then you need to think about high surgical risk. In heart transplant candidates with prior cardiac surgery, this additional risk should be factored into the comprehensive assessment with transplant eligibility. Class 1. In heart transplant candidates with circular aortic calcification, or porcelain aorta, the benefit of heart transplant is uncertain due to the risk of high perioperative mortality and stroke. Class 2B. The last two factors are obesity and age. The obesity, specifically, it varies with center, but BMI of 35 is a common cutoff. The guidelines say, in adult heart transplant candidates with a pre-transplant body mass index of more than 35 inclusive, weight loss to achieve a body mass index of less than 35 is reasonable before listing of heart transplant to improve post-transplant outcomes. Class 2A. The age varies with center, but age of 70 is a common cutoff. The age cutoff for LVAD is much more lenient than the age cutoff for transplant. The guidelines say, in patients with advanced heart failure, age 70 years or less, evaluation for heart transplant is recommended. In patients with advanced heart failure who are over 70 years of age, evaluation for heart transplant may be considered in carefully selected patients depending on their functional status and control of comorbidities, taking into account the need for specialized post-transplant care for older patients, including the need for tailored immunosuppression. Class 2B. I know that was a very long section, but I think it's beneficial to understand these exclusion criteria for heart transplant when we're talking with heart transplant colleagues. Now let's move on to the levels of listing for heart transplant. Pre-2018, UNOS levels for waiting for heart transplant were 1A, 1B, and 2, and these were extremely broad. They were not very effective in differentiating between sick patients. Post-2018, there are 6 UNOS levels for waiting for heart transplant, with 6 being the lowest level and 5 being on the wait list for at least one other organ at the same time. For your maximum yield, I will only tell you about level 1 and level 2, which are the most acute levels, and if you need to look up the rest, you can look up the rest. 3 things qualify you as level 1. Having VA ECMO is one. Another is non-dischargeable, surgically implanted, non-endovascular BiVAD. And 3 is mechanical support device with life-threatening ventricular arrhythmia. So those are the 3 things that qualify for level 1 listing in UNOS. There are 6 things that qualify you for level 2 listing on UNOS. 1 is non-dischargeable, surgically implanted, non-endovascular LVAD. And notice this is in contrast to the BiVAD in the level 1. 2 is BiVAD, RVAD, or total artificial heart or single ventricle patient who has a VAD. 3 is mechanical circulatory support device with malfunction. 4 is percutaneous endovascular mechanical circulatory support device. 5 is an intra-aortic balloon pump. And 6 is VTAC or VFib. Now, in terms of serial testing while on the wait list, according to the 2024 heart transplant candidate guidelines, right heart cath should be performed on all adult candidates periodically after listing until transplantation. For patients with potentially prohibitive pulmonary hypertension, a vasodilator challenge should be administered to document reversibility to accepted levels. That's a class 1 recommendation. Serial CPET testing after initial testing for heart transplant may be considered in patients with change in clinical status or in patients who remain on waitlist for more than 1 year. Class 2B. However, changing patient listing status solely on a criterion of a peak VO2 measurement should not be done. Class 3, no benefit. Serial assessment of serum creatinine and estimated GFR is recommended for patients on the waitlist. The frequency of monitoring of kidney function is dictated by the clinical status of the patient, class 1. Serial assessment of liver function is recommended with serum liver function tests such as serum albumin, bilirubin, or INR, biochemical assays such as AST, ALT, or GGT, and MELD-XI score. Further investigation should be considered when worsening liver function is suspected, including consideration of repeat abdominal imaging, hepatology consultation, and liver biopsy, class 1. Regarding vaccinations and screening, should the patient remain on the waitlist for more than 1 year, annual influenza vaccine is recommended prior to the influenza season, and COVID-19 vaccination is recommended per regional recommendations, class 1. Repeat screening of patients can be considered in patients who remain on the waitlist for more than 1 year, class 2B. Repeat screening of patients on a waitlist should be done after a known relevant infectious disease exposure, Class 1. Patients on the waitlist should undergo age-appropriate cancer screening per current clinical guidelines for the general population, Class 1. There's also an important part about HLA, human leukocyte antigen, and ABO sensitization. Screening for HLA antibodies recommended every 3 to 6 months for all actively listed patients, Class 1. Screening for HLA antibodies recommended approximately 3 weeks after a potentially sensitizing event, Class 1. Screening for HLA antibody can be considered as soon as 7 days after potentially sensitizing event in patients with previous sensitization or expected memory response, Class 2A. In patients awaiting transplantation, it is reasonable to reduce the risk of de novo sensitization by minimizing exposure to HLA antigens using leukodepleted blood products, single donor or matched thrombocytes, and decellularized homografts when possible, Class 2A. Finally, we should know something about delisting. Ambulatory patients on guideline-directed medical therapy should be re-evaluated at 3 to 6 months for pharmacologic and device therapy. So 3 to 6 month intervals. If they have improved significantly, they should be considered for delisting. That's a Class 1 recommendation. Patients on LVAD therapy for myocardial recovery resulting in device explant may be delisted, Class 2B. After delisting, follow-up every 3 to 6 months by heart failure specialists is recommended to identify deterioration, Class 1. Thank you for sticking with me. We have covered pre-transplant topics, advanced heart failure definitions, indications for heart transplant, exclusion criteria for heart transplant, levels of listing for heart transplant, and serial testing while on the wait list. Stay tuned for the next episode where we talk about post-heart transplant issues.
This podcast is intended for qualified healthcare professionals and is designed for training purposes only. These materials should not be used for direct patient care or as a substitute for independent clinical judgment. For more educational content or to submit suggestions, visit www.rehu.com/meded.